All right, welcome to HMP 401. This will be our first lecture. And remember, these lectures will tie into our textbook. So you should be reading the textbook along with the lectures. The lectures are meant to be a supplement to the textbook and are not meant to replace the textbook. So you'll be responsible for materials in both. For those of you who are not are listening but not participating in the class, we are using Shi and Sing. I'll put a link in the notes so that you can acquire the book if you want to follow along. All right, so chapter 1, just the introductory materials here. We're thinking about broadly why are we studying the U.S. healthcare system? So first of all, how much we spend on healthcare has been growing exponentially since the 60s. So in the 60s, we spent almost nothing, relatively speaking, on healthcare in the United States. And today, in 2020, we spent about $4.2 trillion on healthcare. And that number is a crazy, huge number. And what I want to do is put that in perspective and say, okay, what does that mean? Well, framing it as a percentage of GDP, which is the gross domestic product, or you can think of it as all of the money that was made from making things and selling things in the United States. It was about $20 trillion back in 2020, and we spent about almost 20%, about 18% of our GDP. So of all the money made in the United States, about 18% of it was spent on healthcare. So that means that's basically like 20 cents on every dollar that's created in the United States is being spent on healthcare. So that's a good reason to study it. We also need to think about major programs, Medicare and Medicaid, which we'll talk a lot more about as we go through the course, but these are federal and federal state programs and how much we're spending on those. So Medicare, just getting our terminology here, is primarily a service for the elderly and the disabled. Medicaid is a poverty program meant for people who can't afford healthcare for various reasons. And there's some changes in the program over the years. And then you can have what we call dual eligibles, which are people who qualify for Medicare and Medicaid because of their socioeconomic status. So you can have a poor elderly person who qualifies for both Medicare and Medicaid. So those are called dual eligibles. And we created Medicare back in the early 60s. Medicare and Medicaid were created back in the early 60s. And back when they were first created, we were spending almost nothing on them. And in 2020, we spent 1.5 trillion on them again. So, we are spending massive amounts of resources on healthcare and provision of healthcare, and Medicare and Medicaid being taxpayer funded programs. That means you're paying for those. So when we look at Medicare and Medicaid as a percentage of the federal expenditures, you can see again, we started the program back here. So nothing was spent on it then. And it has gradually progressed to over a third of the federal government. So when you look at how much, all of the money that the federal government spends, it currently spends about a third of all of the money that the federal government spends is spent on Medicare and Medicaid. So the challenge here is if the federal government is spending a third of its budget on Medicare and Medicaid, what is it not buying? And so this is a term for this is called crowding out. And so if we're going to spend a third of the budget on Medicare and Medicaid, that means we're not buying something else. And that something else could be a whole variety of things that are good, right? Like schools, parks, funding research, and so forth, that we're not going to be able to afford because we're spending so much money on Medicare and Medicaid. And I'm not saying that that's a bad thing, right? Healthcare is a good, but so are schools, so is research, so are parks, right? National defense, all those things, they're all good, but we have a limited amount of resources. And as we commit ourselves to spending more on healthcare, we have to therefore sacrifice something else. So the question to you as we go through this is, what would you be willing to give up? So let's think about the U.S. healthcare system. The U.S. healthcare workforce is over 16.4 million people. So think about that. Millions of people earn their living working and in the healthcare system and providing healthcare in various capacities. Almost a million active MDs, about 70,000 DOs, which are doctors of osteopathy, which is you may not, depending on where you're from in the United States, you may or may not be familiar with the doctor of osteopathy, but there's a pretty good chance you've been treated by one because they're quite common and they are physicians. Right? So there's really no difference. There's no fundamental difference today between a DO and an MD. So you wouldn't even know. You'd go into a hospital and you might be treated by somebody and you wouldn't even know that you're being treated by a DO because there was no fundamental difference. And we will talk about some of the historical differences. We've all seen nurses, 2.6 million nurses. There's almost 6,000 hospitals and so on. So you get the idea. There's a lot of people working in this, and there's a lot of organizations helping to provide that. Our book talks a lot about the healthcare system. And what do we mean when we say that we have a system? And our book keeps talking about it. And so I like this from The Princess Bride. You keep using that word. I do not think it means what you think it means. So I'm going to come out right up front here. I'm going to take some issue with our book throughout this course of the lectures. So those of you who are in the class listening, you'll hear me kind of reference the book. And at some points, I'm going to take issue with the way that the authors approach it, because the authors tend to think of a system as something like they think of the health system and political systems. In my opinion, they think of them as sort of a mechanical system like this. This is so this would be called a complicated system. It's mechanical. You can see it. It's really, there's a lot going on there, right? But if you have enough time and enough skill, you could make that system work, right? You can make all these cogs turn at the same time and everything works just right in perfect precision. And so if you have a view of human society as like a watch, then the policymaker becomes a mechanic who tweaks this knob here and tweaks that cog there, and pretty soon everything is firing and moving in just the right way. And with enough time and enough resources, you can make this thing do what you want to do. And the interesting thing is, the clock doesn't push back. If you change, if you want to go in there and tweak, some part of the system, the clock doesn't push back and change in response to what you're doing. It just sits there. It's inert. It's waiting for the mechanic to tweak. So that's one view of a system. And I think this is the view that is supported by the authors of our textbook. And I think this is the view that is supported by those people who are fans of central planning. The view of system that I have, particularly of human systems, so social systems, social organization, is that it's, rather than being complicated, it's complex, right? And so what do we mean by complex as opposed to complicated? Because certainly that's complex, right? But there's a fine difference here. Complex means that the system is organic, that it changes, that it's evolving. And so I like to think of a school of fish as a complex system. Each of these fish is pursuing his or her own ends, right? They're out there trying to get some food and not get eaten and not be the food for somebody else, right? And so you can't direct a school of fish. You can kind of influence it, but each of the fish is going to see what you're trying to do, and then the fish are going to respond to what you are trying to do, and they're going to respond by pursuing their own interests and their own needs, and they're going to change, and they're going to change in ways that are extremely difficult to predict, and they're going to change not only in response to you, but they're going to change with respect to what the other fish are doing, right? So that's why, and, that's just fish, right? Not very intelligent beings. Take human beings who are capable of thinking far out into the future. Sometimes they don't think that far out into the future, but capable of making plans and thinking far out to the future, and imputing what you are trying to do. And pretty soon they start gaming the system, right? So systems, right? Human systems are not like clocks, because if the system is made up of humans, right? A human system, like a healthcare system, is made up of human beings all pursuing their own ends, not inert pieces of metal, right? So when you try to manipulate a human, the human, reacts. Whereas a piece of inert metal is just going to sit there and let you do what you want to do with it. So complex systems tend to be are best thought of as organic, right? And constantly changing, and they respond to changes in the environment and to any changes in manipulation. So when we talk about a system, a human system, it's better to think of it as a school of fish than as a clock. Right. So the U.S. U.S. healthcare delivery, or health services delivery system, broadly defined, right? We have some major components of the system and the processes that enable people to receive healthcare. So a restricted definition is the act of providing healthcare to patients. Right? So we think of direct care as the provision of care, but we're going to talk about a much broader sense of healthcare and healthcare delivery and the creation of health throughout this course. Now, people who talk about health policy see healthcare as like one of the essential goods, and it is, right? We need health and healthcare in order to survive. So the objectives of a health system, of course, are to enable all citizens to receive the healthcare services that they need, and to deliver those services at in a cost-effective manner, and meet high quality standards of quality. So we'll come back to the iron triangle of healthcare later on in this course, but cost, quality, and access are the three things that we're just talking about right here. Can you get access to care when you need it? Can you get it at a reasonable cost? And is it high quality? We'll talk later about how people who are involved in healthcare tend to prioritize healthcare over everything else, right? And if they are involved in health policy, they'll tend to make healthcare a priority over, say, schooling or other goods. But in the end, there's no free lunch. What are you going to be willing to give up? Are you willing to give up policing? Are you willing to give up public spaces? Are you willing to give up education in order to get more money and resources to fund healthcare? So part of the challenge of a health system is it is embedded in a larger system of well-being that all of the services that we want and need to have a functioning society. So healthcare is just one part of a larger system of well-being in the United States and everywhere. So the U.S. healthcare system, right, it's unique. It's not a system in the sense that it's not centrally planned. And so your book is very much like, hey, the U.S. doesn't have a healthcare system. I beg to differ. It does. It's just not a centrally planned health system. And so in that sense, it's not a health system in a centrally planned sense, because there's no universal healthcare provided by the government, financed by taxes. There's no entitlement to healthcare in the United States, right? The United States, there are some people who believe health care is a human right. In the United States, we do not have that in our Constitution. We have a right to a whole bunch of other things: right to free speech, right to be free of the government coming into our homes without a warrant, the right to be, basically be left alone. That's a big part of being an American, is the right to be left alone. But what we don't have is an entitlement to healthcare. We don't have, we don't have an entitlement necessarily to income and so on. So no other country quite has that level of, leave me alone-ness that the United States has. And that comes from our historical origin stories that we tell ourselves, and we'll talk more about that in later chapters. We have some serious dysfunction in terms of cost, access, and quality, in part because of that. Right? Other countries have more government involvement in organizing healthcare as a system. So let's talk a little bit about that very quickly, because I think it's important for you to understand. So when I think about the macro organization of society, and specifically the macro organization of the healthcare, the provision of healthcare in a country, we can kind of think of it as on a spectrum between a socialized system and a free market system. So a socialized system, what we mean by a socialized system is it's centrally planned. Some government agent, right, or agency organizes access, cost, quality, and access. It organizes the system. And so on the far extreme, and the UK, right, Great Britain, is pretty far toward for its healthcare delivery system is pretty highly socialized, right? They have a national health service that provides, and I'm going to use scare quotes here that you can't see, free healthcare to all UK citizens. It is a centrally planned organization, so there's a bureaucrat sitting there making plans about where resources should be, what kind of healthcare everyone is entitled to, and so on. So it's centrally planned. It is government, meaning taxpayer funded, right? Because the government doesn't actually have any money. The government has money because it collects taxes, and it's government run. So hospitals in the UK are owned and operated by the British government. On the opposite end, and so the UK is, not a pure socialized system. So I'm not saying that, but it's pretty far towards socialized. On the other extreme, you have the free market approach, where services emerge through competition. So in the United States, hospitals, for the most part, are privately owned and privately operated, whether they're for profit or not for profit. They're private. They're not, meaning they're not owned and operated by the government. There are some that are owned and operated by the government. We'll talk more about that later. But for the most part, healthcare services are delivered in a somewhat competitive market. They are privately, for the most part, privately funded, meaning individuals pay for healthcare, and the services are privately provided. They're privately run. So here in the Seacoast, we have a number of hospitals, some of which are for profit and some of which are non for profit, but they have a board of directors and they are privately run. Now the U.S., you can see I haven't put the U.S. system all the way to the right. Why is that? Well, because we have a huge amount of government planning that goes into the U.S. healthcare system. So our book, I think, erroneously alludes as if the U.S. is way over here to the right, and really not true. So when I say privately, so part of the reason like the U.S. to the left here is when I talk about, say, privately funded, over half of revenue from most hospitals today comes from Medicare and Medicaid, which is a government taxpayer-funded health insurance program. So it's mostly not, right? So the typical hospital, most of its revenue doesn't come from private sector insurers. Over half of their income comes from government-funded programs like Medicare and Medicaid. So that's why I put the U.S. farther to the right, but still there's quite a bit of government planning and government interest and influence on the delivery of healthcare in the United States. So one of the things to think about, another thing to think about with the United States in particular, is how big the United States is. So here's some of so this is the top, the 22 largest countries in the world. And I wanted to include the United Kingdom on there because our book talks so fondly about the UK system. And I want to make a point here about, about the number of people, right? So we have China with, say, almost 1.4 billion people, India with almost 1.4 billion, and this was in 2019. So my understanding is India is set to pass China actually in population, in part because China's population is starting to shrink and India's is still growing. But be that as it may, the top two are still China and India. Whether which one is number one, as I talk to you today, is kind of up in the air. And the number three being the United States at a fraction of China and India, but still a multiple of Great Britain, which again are the United Kingdom, which our book is again so fond of because they so admire the National Health Service. Here's what I want to make a point of. Imagine that you are planning a vacation, right? And you're going to go with some friends. And imagine that you have, let's go down here. Imagine you're Sweden and you have 10 friends that you're planning a vacation for. Planning a vacation with 10 friends would be really hard. I mean, think about that. Like, how many times do you plan a vacation with, say, like 2 or 3 friends? And now you're trying to figure out, what does, Susie want, and what does Bobby want, and what do you want, right? And now make that into 10 people. That's a crew, right? That's a crew that you're starting to try to figure out, what are the interests, what are the minimum desired needs to make everybody willing to go, and not be like, hey, what you're planning is just not going to be fun, and I'm out, right? And on the other hand, make everybody happy. Well, if you've got 10 friends, that's pretty complicated, right? So 10 friends, or in this case, 10 million friends, right? Now take that up to the scale of the United Kingdom. Well, now you're talking about 66 friends. The difference between planning something for 10 friends and 66 friends is enormous, right? That's just you're gonna have to have committees, and you're gonna have to, think through all kinds of stuff. Now take that to 5 times bigger, to the United States, and you can kind of quickly see, that's really hard. The United States, and we see a lot of commentators will say things like, the United States is the only developed nation that doesn't have a national health service of some sort. Yep. But we're also 5 times as big as Great Britain. We're 32 times the size of Sweden. So Sweden is the size of Massachusetts, right? So if you were trying to build a national health service or develop some sort of central plan to meet the needs of your country, it's a heck of a lot easier if your country is the size of a state rather than the 3rd largest country in the world, which is the United States, right? So when we talk about central planning and anything that's going to be centrally planned, you have to remember that the challenge of planning anything increases exponentially with the number of people that are involved. So imagine going and just hold that in your mind. Imagine trying to make a plan for a vacation with, say, 3 friends or 10 friends versus 60 friends versus 330 friends versus 1,400 friends, right? And there's a reason why China and India don't have a national health service, and they have very little national health policy, is because it's so hard to meet the needs and desires of larger and larger populations. So when you have these tiny European countries, and people who are fond of central planning look across the ocean from the United States and say, oh, Sweden does such a great job. Yeah, that's because they're 1/32 the size of the United States. They are the size of one state, right? So much easier to have a health policy if you're the size of Massachusetts for your entire country than if you are the size of the United States. So the U.S. healthcare system, so one of the questions we'll be asking is, should the federal, state, and local governments have a larger role in organizing the U.S. healthcare system? What other U.S. industries are as regulated as the U.S. healthcare system and work better because of it? Well, there are relatively few systems, right, in the United States that are more regulated as a result. Excuse me, are more regulated than healthcare. Basically, banking and financial services are the only other, and maybe say the nuclear power industry. Those are probably industries that run that have more federal regulation, more state regulation than the healthcare sector does in the United States. So the question to you would be, does it run better? Well, those of you who were hanging around in 2008 saw the Great Recession and how poorly that's run. Those of you who've been living in, been alive in the last couple of years and seen how government poured trillions of dollars into the economy and has now caused a massive inflation. Does the federal do central planners actually make things better? I'm going to argue no, and you'll hear me argue that throughout this course. So a counterpoint to your book, which is very fond of central planning. So let's talk a little bit about health insurance. So this is measures 2021. You can see down here that you can get this PDF. So this is looking back from 2022. So in the United States, how many people had health insurance? Well, about 92%, about 8% were uninsured. Who's uninsured? It really depends. So these are people. So any insurance includes Medicaid and Medicare. So we do have some people who probably would qualify for Medicaid, but are homeless, mentally ill, and basically not capable of filling out the paperwork. So there's that piece. So most people in the United States do have health insurance. Now, we'll come back to that later, but health insurance is not the same thing as having access to health care. Some providers don't take Medicaid. They just tell you we're closed to new Medicaid patients. So a lot of physician practices, if you show up and you're like, hey, I'd like to get care from your doctor, and the practice manager will be like, oh, that sounds great. What's your insurance? And you say Medicaid, and they say, sorry, go find somebody else. Now, that's a huge improvement since the ACA, since Obamacare, the Affordable Care Act. We'll call that Obamacare. If you listen to former President Obama talk, he will happily takes on the ACA as Obamacare. He's very proud of that program. So I'll bounce back and forth in calling it Obamacare or the ACA, the Affordable Care Act. But one positive thing that came out of the Affordable Care Act is before 2014, this number was about 16%. So the ACA has successfully cut the uninsured percent from about 16% to about 8%. So it's cut it in half. So that's good. That's a good outcome. So let's break down, of the people who have insurance, where do they get their insurance? Well, 66% of the people who have insurance get it from some sort of private plan. You have employment based. So most people who have private insurance, it's from their employer, and we'll talk about why that is, because in a lot of other countries, health insurance is not connected to your employer, but in the United States, that's the most common. If you're not on a public program like Medicare or Medicaid, you are most likely getting your insurance from an employer. Some people purchase their insurance directly. So a lot of people who are entrepreneurs who are not, so I have a friend who's a photographer, for example. He buys his insurance directly because he doesn't have an employer, right? He's a solo practitioner and he just buys his insurance directly. The marketplace, which is a reference to the Affordable Care Act, required the creation of state marketplaces for health insurance. So some small fraction of people buy their health insurance through the marketplace. TRICARE is a military is the military healthcare system. So I'm a retired Army officer, and I qualify for TRICARE. So what this is, and we'll talk more about this later on, but what this is if you are active duty, so if you're in the service or if you're retired, you are entitled to health care from the military health system. But in many cases, wherever you are, so for example, I was stationed at a small I was stationed at Fort Polk, Louisiana once. So out in rural Louisiana at a fairly large training base. But we had, and I was working at the hospital there. The hospital was basically a small community hospital. So we didn't have a lot of specialties. We really just had basic community medicine at that facility. So if someone had needed, you know, urology care, for example, or needed oncology care, we had to send them out. We didn't have an oncologist on staff, so we had to send them out to the private sector. And TRICARE, when we sent someone out, because we didn't have the healthcare available through the military health system, we used TRICARE to buy the healthcare from the private sector. So there were hospitals and providers in the general vicinity where we would refer people to, and they would get their healthcare through TRICARE, and TRICARE would pay the providers for that. So then thinking about, so that's private plans. So this cluster is private plans. Then about a little more than a third of Americans who have health insurance have it through some other public plan. So Medicare, Medicaid, VA, and CHMP VA. So these are entitlement plans. And you could argue, why isn't TRICARE down here? It's a public plan. TRICARE is technically a employer-driven plan. The reason that I have that is because I was employed by the Army at the time, right? The difference between the Veterans Administration, VA services, and CHMP VA is part of that. The Veterans Administration services you get after you're out of the military. So if you are injured in the line of duty, so if you are parachuting for the Army, for example, and you have an accident and you break your, break your leg, or heaven forbid, you break your back, which happens, and you can no longer serve in the military, then you get discharged from the military, probably medically retired if you're that seriously injured, and the VA picks up your care after that. So then it's so now it's not a employment-based plan. It is an entitlement. I'm splitting hairs a little bit because I think you could kind of slide that back. You could slide the VA back up because the only reason you have access to the VA is because of your prior service. But be that as it may, the census, so this data is from the U.S. Census Bureau. They've lumped it in here as a public plan, so we'll just leave it there. But 18% of people get Medicare, almost 19% get Medicaid. So about a third of Americans get their health insurance from from the public sector. Most Americans get their health insurance from the private sector, and the bulk of Americans get it based on employment, which creates its own problems. All right, so the U.S. healthcare system, what's great about it? Well, it leads the world in medical technology, right? We've got the best, coolest technology, and most medical technology is created in the United States and then diffuses, meaning it gets picked up eventually by the developed world. So eventually it gets picked up in Europe, and then gradually through to other parts of the world. We have the best medical training in the world, right? People come to the United States to get their medical training. Once upon a time, Europe was the best medical training, but the United States has the best medical training for decades. We have the best and most sophisticated research. We have them, right? So because we have that free market where people can make money, based on the work that they do. We have the best research. And then we have the most sophisticated institutions, the most sophisticated products, and the most sophisticated processes. So there are challenges. By no means am I saying that we don't have our problems. Cost is high in the United States. Access is not perfect in the United States. Quality is variable in the United States. But we've got a lot going on. If you get sick and you live someplace else in the world, you're most likely going to, if you're wealthy, you're most likely going to be thinking, I need to get to the United States, right? You're not thinking, you know where I need to go? Great Britain. No, you're coming to the United States if you can. And many of our large systems, so like Mass General, Brigham, Mass General Brigham system down in Boston, the Cleveland Clinic, the Mayo Clinic, these are all big names that have huge international reputations, and wealthy people from all around the world come to those places to get their healthcare because we've got the best care in the world, right? The problem is it's expensive, and it's not necessarily easy to access for everybody. So we'll talk more about those challenges, but I want to really highlight just like how incredible the U.S. healthcare system is. So in this text, we're going to use a quad function model to kind of talk about the components of healthcare delivery. We'll talk a lot more about this, so I'm going to skim through this pretty quickly. But it's got 4 sections. Financing, where do we get the money to buy the insurance or to pay for healthcare? Do we get it, do we earn it ourselves? Does it come from our employer? Does it come from taxes collected by the government? Insurance, and I'm going to talk about what insurance really means, because health insurance, as we know it, is not really insurance. But true insurance, pure insurance, is meant to protect against catastrophic risk, right? And it determines what you are eligible to receive. Then we talk about where does the money come from? How do we get insurance to pay for catastrophic risk? We'll talk about delivery, right? What kind of provider provides the care and receives either insurance payments or payment directly. And then finally, the payment process. How do providers get reimbursed? Do they get it direct? Do they get it from an insurance company? Do they get it from a patient? Do they get it from the government? And we'll look at all that stuff. So we're going to look at it in more detail. We're going to talk about some different kinds of systems. So a national health system is so that we'll talk about 3 systems that are kind of far to the left, right? The farthest to the left on that scale, right, towards a centrally planned system, is a national health system. So this is the system that is run by the British government in the UK, the United Kingdom, right? It's tax supported. So the financing comes from taxes. The government manages the infrastructure for delivery, right? So you're getting healthcare at a government facility by doctors who are government employees, right? So the government provides the delivery. You finance it through the taxes you pay. You get it delivered by the government. There is no insurance in that sense, because and there are no payment systems, because you just show up and get the care. A lot of other European countries, so this is the German model, for example, is a national health insurance system. Excuse me. This is the Canadian system. So national health insurance is the Canadian system. This is where the financing is done by the government. So if you get your care in Canada, you don't have insurance per se, because your care is funded by the government. So it's the healthcare is paid for through taxes you pay to the government. The government acts as the insurance provider and pays and operates the provision of care, but the providers of care are actually private providers. So you'd have your doctor is not an employee of the Canadian government. But if you are seeing if you're in Quebec, right, your provider is not a government employee. But if you're in London, right, your provider is going to be a employee of the government. So the difference is primarily the insurance function and payment function in a national health insurance program. The government steps in and acts as the insurance and payment, um, as well as financing, but delivery is from the private sector. Now, this is the German system, national and social insurance system. So in Germany, um, the government doesn't collect the money, doesn't collect money from you through taxes. They require you to buy health insurance. So this is the mandate that we were trying to create in the United States through the ACA. So, but the difference is we have these in say Germany, we have these regional nonprofits that have a monopoly on providing health insurance. Um, and so individuals and employers are required to buy health insurance through these regional monopoly nonprofit insurers, and then those insurers pay for healthcare, but the healthcare is delivered by private sector providers. So in Germany now, as opposed to say Canada, right? So we start with London, excuse me, with Great Britain. So if you're in London, the government funds your care through your taxes. Your provider is a government employee, and there is no insurance or payment system. If you're in Canada, the government collects taxes from you and provides you insurance through the government, but care is provided by private sector employees. In Germany, there is an insurance mandate, so the government doesn't fund it through taxes. It's private sector financing, but it's a mandate that you have to buy this insurance. And then, but then the provision of care is also private. So there are some different flavors. And then in the United States, we don't have a national system, as we already talked about. All right. So that concludes the first lecture for a first introductory lecture, and we will dive into more details in chapter 2.